trachs because, yeah, you do it all the time in the hospital and stuff. And it's like, true, I do it all the time in the hospital. Working on the ambulance or working on the helicopter, especially in the ambulance, we always had this thing called fight for the driver's seat, where, when that pager went off, if it was a trach patient, if it was a rectal bleed, if it was somebody giving birth, you would see a bunch of grown adults just beating the crap each other, saying, I'm driving. Well, even when the flight phone rings and they say, okay, yeah, you got a kid with a trach, how well do you think it went over when I jumped in the pilot's seat, and the pilot comes walking there, looks at me, and says, I probably couldn't even start it, but yeah, that still goes on today. Anything with a trach, yes, like I said, in the hospital, we deal with it. However, in the pre-hospital setting, it's just you, your couple of partners, and you're in the middle of nowhere in the back of an ambulance. The nice thing about the hospital, we're extremely spoiled. Something goes wrong, we press a little blue button, and especially say it's a child with a pediatric trach problem, within minutes, we can literally have a pediatric ENT surgeon there, or a pediatric anesthesiologist there, or a pediatric critical care physician there. Is that going to happen in the pre-hospital setting? Nuh-uh. So as far as what we're going to be talking about, we're going to become familiar, hopefully, with the different types of trach tubes. And in all honesty, there are just thousands of them out there. That's a whole other day, 2-day-long lecture. We're going to identify some of the common tracheostomy emergencies, as well as review the EMS management of trach emergencies, and to demonstrate some of the basics, the suctioning, as well as some of the advanced stuff, the changing a trach tube. And as a little extra bonus, we have got a family with us from Wonder Lake, Illinois. Don Goulas, he's a paramedic student down, he works with Wonder Lake Fire Department. His wife Jennifer, little son Justin, and the star of the show is going to be Taylor, a little 5-year-old that does have a trach. And coincidentally, they just happened to be up in Wisconsin Dells for their first vacation in 10 years ever. So she's going to be up here, and then after I get done spewing out all my stuff, hopefully we'll have her up here on the stage, and we can get some close-ups with the camera and walk through a trach change. As well as the parents being here also, if you have any questions, they are more than willing to answer them, hopefully. So where are they anyway? Sitting back in the corner. There we go. Alrighty. So anyway, like I said, they'll be our guests today. So as far as trachs go, they have been out there forever. Metal trachs came out, years and years and years and years ago. Everything, again, pediatric patients, adults have all been trached. Years ago, there were literally trach wards in the hospital for pediatric patients, adult patients, and even recently, as far as 10, 15 years back in UW Children's Hospital, we used to have a designated intermediate care unit for children with vents and that had trachs. And what they slowly realized is, well, wait a second, these kids are perfectly stable. There's no reason in the world for them to chew up a $1,300 a night hospital room. Get them out. So anyway, there are more and more of these kids out there in the community, as well as adults. Same thing as far as the emergency trach kits. There's probably some ambulances out there that are still running with this exact same kit. So quick anatomy though, before we sit there and go into this stuff, if you heard me lecture, I'm a stickler on the basics. So as far as anatomy goes, upper versus lower airway. The upper airway, remember, when the patient does have a tracheostomy, they do bypass the upper airway. Purpose of that upper airway is going to be to heat, humidify, filter any inspired air. Heating it, I remember when I was young, I'd go out running or whatever, playing in the winter, and my mom, where is she? She would bitch at me and say, well, you idiot, you're going to go out there and freeze your lungs. Are you going to freeze your lungs? No. So it's going to heat your inspired air, it's going to filter it. Same thing, I'd be downstairs spray painting my guitars or my bikes, whatever, with the Schwinn Candy Apple Red spray paint. For the next 3 days, I'd be picking my nose. What color are my boogers? Candy Apple Red. So it's going to filter that inspired air as well as humidify it. In the winter, you can sit there and see your exhaled air. Same thing happening right now is, I'm losing, an adult averages about a liter worth of fluid loss just by breathing. So anyway, we'll talk about that a little bit later. So as far as anatomy, same thing. We always hear, well, kids are just little adults. Nah, not necessarily. You look over and, when I was making this lecture, I had a pilot looking over my shoulder, and he's looking at the big head, and he goes, oh, I see. He goes, you got the pilot, and in the middle you got the flight nurse, and on the end you got the flight paramedic. And I said, no, the big head, I said, that's the flight paramedic. In the middle, I said, you got the pilot. And then down on the end, that little head with that yippy little jaw that just doesn't shut up, you got the flight nurse. So, anyhow, but as you can, sorry, Sarah. Anyhow, but as you can see though, kids, they're little lawn darts, big old head, tiny little bodies. A couple things though, as far as their anatomy of their upper airway, looking at the little pediatric airway over on the, would be your left side, their airway is very much like that of a funnel where it decreases in diameter. Big old tongue, big old floppy epiglottis, and then a tiny little glottic opening versus that of the adult, pretty much uniform in diameter. Everything is in proportion as far as the tongue and the epiglottis. Narrowest portion of the airway, again, somewhat important to know, the pediatric airway, it's going to be the cricoid cartilage. Versus the adult, narrowest portion is the vocal cords themselves. As far as foreign bodies, with the adults, they say the average size foreign body that they yank out of an unconscious adult due to a foreign body airway obstruction is how big? About about the size of a pack of cigarettes. And something that is even more amazing that I can't get over is normally they say that alcohol is involved. You know, yeah, pretty amazing. But these little critters, though, very important, though, that the narrowest portion of their airway is going to be that of the cricoid cartilage. So looking down their airway for intubation or for using the McGill forceps with the laryngoscope, there might be times looking at their airway, it's actually absolutely clear. However, below, this is from a 6-year-old little girl that was in a car accident south of Madison where they went to intubate the child. Tube passed fine. They went to bag the child. They just could not squeeze the bag. They withdrew the endotracheal tube. The entire distal end of that tube is occluded with the bubble gum. So how many of us eat in the car or chew gum in the car or whatever? You know, when she looks over and sees that Mack truck coming and goes, well, she just aspirated. So tiny little airway again, little infant, big old omega-shaped epiglottis, tiny little funnel shape that again decreases in diameter versus that of the adult. You can see that crescent-shaped epiglottis, big old vocal cords, as well as looking down the glottic opening, you can see the first ring of the cricoid, first ring of the trachea, the cricoid cartilage, which remember with proper use of the McGill forceps, they should reach all the way down to the cricoid cartilage, as well as you can see the tracheal rings continuing afterwards. But again, as far as all the advanced stuff, there's nothing that is more important than basic airway management, learning how to position patients, especially the pediatric patient. And again, they got that big old knob on the back of their head, their occiput. So again, if you are going to be assisting ventilations or bagging a patient, utilize some form of a towel roll or something behind the shoulders, as well as they're even making longboards these days that have a divot for the occiput. And again, bag valve mask ventilation. I cannot stress this enough. This is the one that you absolutely have to perfect. And again, it should be a 2-person job. In the hospital, it can be a 40-person job. However, in the back of your ambulance, in the middle of nowhere, you've got 1 person driving, 1 person thumping on the chest, and 1 person bagging. And that's where you get really, really good at airway management. Alrighty, like this little guy says, enough of this crap, let's talk trachs. So, as far as dealing with a patient with a trach, one thing to remember, long before these kids go home or these adults go home, they get literally, the family as well as any healthcare provider at home gets literally hours and hours and hours and hours, if not days, of training on what to do, to clean it, to troubleshoot it, to emergently change it, etc. These patients are very much like that of a asthmatic that knows their disease up, down, in, and out. When does an asthmatic call 911? After they completely deplete all of their inhalers and stuff. You know, if one of our little kids here winds up coughing out his trach, and if the parents can't get it in, or if that home health care nurse can't get it in, they're going to call us. How many people in this room have changed an infant trach in an emergency? You know, and this is a lecture that we did a couple years back at the Monona Terrace for EMSC. What we wound up doing is bringing in a child with that was vent dependent and trached, his parents, as well as the home health care nurse, who is somewhere here in the audience. The nice thing about this guy is he is one of our PEDS ICU nurses, he is one of our PEDS transport nurses, as well as does home health care on the side. And basically what we had is a question and answer period between the parents as well as the EMS providers, and basically said, what would you expect if you call 911 and vice versa? And talking with one of these families, I asked them, I said, if you call 911, what would you expect if you couldn't get the trach back in? And they said, well, you know, they would come and they would orally intubate my daughter and put a breathing tube in her. And this is from a tiny little town population of like 640 people. And it's like, you know, and when the EMTs, when the family said, oh yeah, you're going to come and intubate my daughter, their eyes just, again, they're like, no, we're going to be still fighting over who's driving. So, so again, like this slide says, these folks are literally your new best friends, because as far as kids go, the parents know them better than anybody, better than we ever will, and especially if they have any special health care needs, that's, you know, that's even more so. So like I said, these are going to be our best friends during the transport, and hopefully we can sit there and steal one or two of them to go with us on transport to assist us. So use them as resources. As far as tracheostomy, it's a temporary opening in the trachea that's surgically placed below the level of the cricoid ring, and we'll talk about that a little bit later. And as far as trachs, kids can get them, adults can get them. The stoma, it's an opening in the neck created for a tracheostomy. And as far as some of this stuff goes, these days with cosmetics being more and more important, there are times that you might have a patient that for whatever reason you just can't bag, and you start peeling away stuff and start exposing them more and more, and you find out that, oh my gosh, hidden under one of these covers they do have a stoma and a trach. There are more and more companies coming out with devices like this to cover up the tracheal opening or the stoma or the tracheostomy itself. So you might have to do some searching. So as far as why a trach, there are multiple reasons. Vocal cord paralysis, inability to handle secretions, head, neck, anatomical differences, high spinal cord injuries. They always say C3, 4, 5, keep the diaphragm alive. You get a high spinal cord injury like the Superman guy, Christopher Reeve, vent dependent with a trach. Laryngeal cancer, long-term mechanical ventilation, again, and plus many more that aren't even on here. So who can have a trach? Basically, again, if a German Shepherd and a cow can have a trach, any human can have one too. Adults, elderly, you name it, they can have it. Teenage patients, they can have them. Pediatric patients, they can have them. All the way down to the tiny little neonates, preemies. How many people have ever dealt with a kiddo this size with a trach? A couple of them, and most of the time it's during critical care transport. However, in EMS, do we have the luxury of sitting there telling which calls we want to go on and which ones we don't? What happens if it's something like this with that pediatric neonatal transport team? This is from, if you look down on the bottom there, that's probably one of the largest pediatric children's hospitals in the nation, Little Rock in Arkansas, that wound up getting in an ambulance accident. And I did a lecture a couple weeks back that one of the guys came up to me and said, well, I've lived in this community for 39 years. And he said, we don't have any children like that in our community. And I said, but correct me if I'm wrong, but don't you cover the interstate? And he said, yeah. And I said, so on the east end of the interstate, you've got Children's Hospital of Wisconsin. On the west side of the interstate, you've got UW Children's Hospital. I said, so do you know who's traveling in every one of those vehicles on the interstate? Who's to say that, God forbid, an ambulance rolls over, or you've got somebody taking their child with special health care needs to the hospital for a clinic visit or something, and something happens. So, like I said, anything in EMS, as you know, can happen and probably will. So laryngectomy versus tracheostomy. Laryngectomy is basically the removal of the larynx for multiple different reasons, which can come back to haunt us. There's a difference between a partial laryngectomy and a complete laryngectomy, or sometimes it gets interchanged with partial trach versus complete trach, where they literally cut off the opening between the upper airway and the lower airway, which that stoma site is going to be the only route down to the lungs, down to the airway. And then the tracheostomy, where they actually put a tube in, depending on the surgeon, either in between the second and third or fourth tracheal ring, which we'll talk about a little bit later. So as far as the frequent speed bumps, patient-provider communication. Now again, with that trach tube being located below the vocal cords, a lot of times these patients can't talk for whatever reason. So there are a couple different things out there. And again, we think about the trach patient that has just specifically that trach problem wrong with them. However, you got to be thinking about all the other medical stuff or the trauma stuff that can go on, where you might have to communicate with that elderly patient with a trach that's having chest pain. So if they do have any of this stuff to assist them with communicating, by all means, take it with you. A couple different things. These days, there's little keyboards and stuff, as well as the, I'm not quite sure of the name, I've heard it called Mr. Microphone or the cancer kazoo or whatever, that goes up against the larynx and vibrates. Again, take it with you. Other things that are out there, tracheoesophageal voice prosthesis, which is basically just a tube that goes in between the trachea and the esophagus. Basically, the patient breathes in, plugs it, and then exhaled air goes up through the vocal cords so they can vocalize. They're not going to be able to sit there and sing or whatever, but they should be able to hopefully communicate with you. As well as one of the other things I didn't even think about when I was making this lectures this morning, our little all-star, Taylor, wherever she is, starts doing sign language. And so again, sign language is also another, if you have the ability to know what they're saying. So thank goodness we had Mom there translating for me. So other things that are out there is there are special trach tubes out there which are called fenestrated trachs, which do have an opening on the back of the trach where, again, the patient breathes in and then either plugs the stoma or they have a speaking valve, which we'll talk about. Exhaled air goes through the fenestration up through the vocal cords, and again, these patients can vocalize. Other things that are out there are speaking valves, which fit on the end of a tracheostomy tube, which I thought about this. If you threw that on the picture of the German Shepherd, if the thing would be able to bark. But basically, it's a one-way valve, very much like that, a non-rebreather. It fits on the trach just by friction, and basically when it breathes in, the patient breathes in, they opens up that one-way valve. However, when they exhale, it shuts off that one-way valve, forcing air to go up through the nose and mouth, or through the vocal cords, so again, they can speak. One thing to keep in mind, though, is, again, these things are held on there just by friction. If you do have to emergently ventilate this patient, that has to come off in order to hook your manual resuscitator up. So, like I said, normally they just twist right off. So keep that in mind. Other frequent problems is secretions. As far as, again, we talked about that upper airway being able to heat, humidify, and filter any inspired air. A lot of times these patients are on some type of heated humidity device to keep their secretions liquefied. However, after a while, if it gets to be a pain to keep that on, they take it off for whatever reason, and after a while, secretions do become a problem. Other things that are out there are what are called artificial noses, or heat HMEs, which are heat moisture exchangers, which are basically a little device. It's about the diameter of a roll of film that has basically some almost like crepe paper inside, that basically when the patient exhales, it saturates that paper. When they inhale, it rehumidifies their inspired air. And that's what the dog has on, and that's what our little kiddo here in the swimming pool has on. However, keep in mind, after a while, these things do become pretty well gunked up, and again, that's going to lead to increased resistance. So you might, if you have a child in respiratory distress or an adult, just by popping that off might assist them with breathing easier. And again, if you don't keep those secretions liquefied, that's basically a completely plugged endotracheal tube due to secretions. And if you look up on the pilot line up there, that is a size 8.0 endotracheal tube. It's about the size of a garden hose, so I'm guessing that's about the size of a Big Mac in order to occlude that. So quite a bit of secretions there. So as far as types of trachs, again, this is a whole nother lecture. Multiple different sizes out there. These days, most of them are made of some variation of plastic, PVC or whatever. However, there are a few of these in the upper left-hand corner still out there. They're what are called Jackson trachs. If you work at a larger facility like a VA hospital or a state-run institution, or you do wind up doing transports, you might wind up with somebody with a Jackson trach. Where the oddball thing about the Jackson trach is, number one, it goes patient to patient. 1 week, you'll have it. Hopefully they'll clean it, then it goes to her. Hopefully they'll clean it, then it goes patient to patient to patient. So you might have a trach in that patient that might be 40 or 50 years old, and it might have been in literally hundreds of patients. However, the newer ones these days are disposable, as well as single patient use, obviously. The other thing about the Jackson, though, is the most important thing is federal law mandates that every manual resuscitator out there must hook up to every trach and every endotracheal tube out there. With the exception of this one here, the Jackson, you need a special adapter called a Roosh adapter, or if you want to play MacGyver, if you have a size, say, 6 Jackson trach in, and you don't have that adapter, a size 6 endotracheal tube hub, or whatever size you're using, whatever size trach that is, you can just pull the hub off an endotracheal tube and that will work. But like I said, they are out there. As far as the prepackaged trach tubes, I'll pass a couple around just to show you what you get when you wind up opening it up, but basically it's everything for the most part to insert a trach, with the exception of a few items that we'll talk about a little bit later. As far as the different types, though, there's single cannula types and double cannula. The single cannulas generally are reserved for the little kiddos, preemies, neonates, infants. Reason being that they're a single cannula, meaning there's just one tube, is that the diameter of the pediatric trachea itself is only a couple millimeters in diameter. Now we're sticking a tube in that, and if we wind up sticking yet another tube inside that, anytime you decrease the diameter of anything, be it a endotracheal tube, a fire hose, an IV, what happens to the resistance? It goes through the roof. So that's why they're single cannulas, because you just don't have that room to place yet another sleeve in there. More importantly, though, we talked about secretions a little bit ago. If you have a tracheal tube that is only a couple millimeters in diameter, the tiniest amount of secretions can literally plug that thing off in a matter of seconds. But also in there you get the trach tube itself, as well as you get what's called an obturator, which is a little rounded end that goes inside the trachea to ease inserting it through a stoma. I'm going to pass some of these around, and hopefully with whatever 500 people we'll get by the end of the talk, you'll all be able to see it. And where's Steve Metz? My guess is these are probably going to wind up on eBay by the end of the night. And there are uncuffed ones, cuffed ones, as well as one of them does have a artificial nose on it. Just practice pulling that artificial nose on and off. Like I said, it's held on there just by friction. So the single cannula, again, you can see here, multiple different sizes all the way down to the preemie ones. And as far as the different types, there's neonatal, there's pediatric, and there's adult ones, which we'll talk about. But again, just looking at the size of that, very, very small diameter. Once you get up to about a size 4, 4.5 or so, some of the pediatric ones start to have cuffs on them. However, they are still single cannulas. The double cannulas, once you get a little bit larger diameter, they do have what's called an inner cannula that slides in and locks in place by a couple different ways. Either twist locks in, which is like the one up here, which is generally a reusable inner cannula, or there are some disposable ones that have almost like a little clothespin top on, which we'll show you here in a second. And again, these are all inner cannulas. And these things can be a real lifesaver as far as if the patient does have an obstruction right there in the cannula. It can be easily swapped out, removed, and exchanged for a new one. However, my guess is long before 911 gets called, do you think the parents or the home health care nurses are going to attempt to change the inner cannula? Oh yeah. So as far as the different types, the disposable ones just have a little pinch clasp on there. You just go ahead and squeeze it with your index finger and thumb and pull it out. One in the center there, as well as one in the center is you just rotate it on 90-degree turn and it clicks, and then the one on the end also is just with a little clasp. Some of the very important information on these trachs that you can pass on during your report to the hospital, besides just telling them, hey, you're bringing a trach patient, if there is truly a problem with the trach, some of the information that we would love to have is on the wings of the trach. Take a look in the information that is circled. Looking at this first one on the left here, it's a Shiley, it's an uncuffed, and it's a 4.5 pediatric size trach. And like I said, Shileys come in neonatal, pediatric, and adult. But the numbers over here on the other side, the right side, those are the important ones that we really need to know. 4.5 ID stands for 4.5 millimeter internal diameter of the trach tube itself. The bottom number is 6.5 OD, which stands for the outside diameter. If we don't have one of those in our supply, we can hopefully cross-reference it with another trach vendor. And as far as the trach vendors or manufacturers, there's Shiley, there's Bavona, there's Portex, there's Roosh. Same thing, there's multiple different vendors, and if we don't have that exact same trach in stock, we will get the next closest thing. And even the box, if they do have an empty box, by all means bring that in also, because that has multiple, same thing, it's got the different sizes, as well as, besides having the internal and outside external diameter, also has the length of the trach. And again, we can hopefully have something ready for you once you roll in the door. So as far as assessment and intervention, if you are going to be responding to a person with a trach, this is the mode that you have to jump into in a heartbeat. And who's this guy? McVicar. Because like I said, long before they call 911, they're going to exhaust every possible thing before you get there. So some of the common problems with trachs, the pneumonic dope is used quite frequently for dislodged, obstructed pneumothorax and equipment. And we'll run through each one of those. Dislodged or decannulation. I remember the first time being a new RT student and walking into some little critter's room and they're holding their trach, and it didn't even faze me. And it's like, well, wait a second, that's supposed to be in your neck. And, a couple different populations of kids. First, the ones that realize, well, wait a second, I realize that when I pull this thing out of my neck, the ventilator alarms and everybody comes running and I get attention. And so instead of, hitting that call light and knowing nobody's going to show up because they're understaffed or whatever, instead they just pull out their trach. Or the other type of patient that, Taylor in the back needs her trach because basically otherwise her trachea collapses. And basically that, after she does that, how many times mom, once or twice, and realizes, well, wait a second, I can't breathe now. And she realizes not to do that anymore. So anyway, dislodged, like I said, it can happen. This little critter here doesn't even realize that his trach is out. He's got a birthday cake in front of him. So, but again, he's doing okay. So as far as dislodged, trachs may become dislodged if there's improper airway positioning, when the trach ties are loose, which we'll talk about here in a little bit, when younger children can reach and untie their ties. Again, they're kids, they do whatever. Vigorous coughing or sudden movement, again, significant weight changes. And again, this is something that not only with the trach itself, we see this also with the combi tube, we see this with an endotracheal tube. How many times do you get to the hospital, you've got that patient with a combi tube in place or whatever, and you're going to be moving them from your ambulance cot over to the ER bed, and you do the 1, 2, 3 thing, and somebody leaves the manual resuscitator hanging off the endotracheal tube or the combi tube. Then you're looking on the floor and you got the manual resuscitator with the combi tube hanging off and you've got an extubated patient. You know, any type of movement, just give that patient a couple extra breaths, disconnect, then move your patient. And then sometimes also with cuffed trachs, you can have some problems. So if that trach does come out, first off, why do they have it? And do they truly need it right now? And a lot of times, sometimes the patients wind up coughing out their trach and pulling it out or having it yanked out or whatever, and they just do fine for 20 minutes, 30 minutes, whatever. And again, like it says there, is it needed? Do we have to sit there and go nuts trying to get this thing back in, or will they do okay for that 20-minute ambulance trip to the hospital? And again, this is where the parents as well as the home health care folks come into play, and just ask them, you know, do we need to sit here and go nuts trying to get this thing back in that you couldn't get back in, or will we be okay here for a little bit? And this is what it truly comes down to. If you do get to the point of having to put one back in, it comes all down to preparation. Proper positioning of the patient, which we'll talk about. The ready-to-go trach set. I guarantee you, anybody that has a trach usually carries around a backpack with them or something that has absolutely everything to replace that trach as well as do everything else. So the ready-to-go trach set includes a trach with an obturator, ties, ready to go, suction equipment, bag valve, and masks, as well as normal saline and sterile water. And we got some pictures here, as well as Don brought their to-go bag that we'll show you here a little bit later. Inside here, this is one of our frequent flyers where, again, inside that backpack has got absolutely everything to take care of that child. Take it all, spread it out, and again, everybody's different. Everyone kind of custom makes their emergency bag to what's going on with their kiddo. But again, manual resuscitator, backup trachs, suction materials, etc. As well as some of them even have a specific pouch just for that emergency trach replacement. So the rules for inserting a trach tube: one possible, lubricate the tube with some type of water-soluble lubricant, either be it Surgilube or KY jelly. If Surgilube is not available, use saline or water. That works fine also. It's always a two-person job. And again, in the hospital, we've got the luxury of having 40 people in the back of the ambulance. Good luck, you know. And here they make it look so simple. But like I said, if you get called to this, in the field, it's going to be tough. And here, what they're doing in this picture here is, again, they're taking a towel roll, placing it behind the shoulder blades of the child to basically bring their neck up, elevate their shoulders a little bit, and ease insertion a little bit. And as far as training goes, we sit there and we train the parents on the little trach dolls as well as our staff, and sit there and say, oh, it's easy, you know, you just sit there and you just pop it in. Real life, this is who you're going to get called to. They're going to say, we can't get it in, now it's your turn. Or worse off, something like that. So this is where it takes that two-person job and turns it into a six-person job or a seven-person job. So again, like I said, if you get called out to a dislodged trach that they can't get back in, you know, again, go for that driver's seat. So as far as insertion of a trach tube, if you meet any resistance, even though it's lubricated up and you've got that stoma spread apart, if you meet any resistance, stop. Just last Monday, I was able to, this is a girl by the name of Sarah. She's a full-time firefighter medic down in Illinois, who just out of the blue suffered from Guillain-Barré last year, wound up losing pretty much all muscle tone whatsoever, to the point that she was mechanically ventilated and trached. And I talked to her on Monday about trach changes, and I said, what do you remember about them? And she said, oh my gosh, she said they would have people that were just so gung-ho that trach was going in one way or another. And she said that there were times where it was like an elephant standing on your neck because there was so much pressure. Looking at this, I want you to look at the upper right-hand corner of these next couple slides here. It's the inside of a trachea with a bronchoscope looking down through the glottic opening at, basically it's going to be at the tracheal ring where that trach is going to be coming through here. And here you can see that you've got pretty decent C-shaped cartilage there for the most part. Once that trach slowly starts to come through with the obturator, and then pressure is starting to be pressed down, you can see how that tracheal ring is starting to collapse. Think that's too much pressure? To the point that your trachea is already collapsed? If you meet that much resistance, probably something's going on. So, however, after you get that tube in, that obturator device, which gets slid into the cannula first to ease the insertion, after that gets put into the trachea, and your tube is in, then an obturator has to come out. And it's very important here, you notice what this other person is doing with their hands by holding that trach tube in, because I guarantee you, anytime you stick anything into a person's airway, generally the first thing they start doing is coughing and hacking. And if somebody doesn't have a decent handhold on it, that gets coughed right back out. So one person to hold the trach, one person to to pull the obturator. And then if it is a trach that does have an inner cannula, we'll go ahead and slide that in. And with the inner cannula in place, if it's got the little, if you might have to rotate it to lock it in place, otherwise you'll have to use a little clasp to pinch it and secure it. And after insertion, again, we're going to go ahead and confirm placement very much like that of an endotracheal tube or a combi tube. Listen bilaterally and make sure that you do have adequate chest rise also. We had a patient several years ago in the hospital that they just couldn't suction down past, they said, well, we can only suction so far, and the patient just doesn't tolerate it and stuff. And what had happened is this patient had multiple double chins, and they were, again, just so gung-ho getting that trach tube back in place that they literally created their own pathway down into the subcutaneous tissue, missed the trachea altogether, and just could not figure this out, what was going on. And again, that's when you got to jump into the McVicar mode. And this patient was fine, he was protecting his airway fine, but what it actually took is, we took a suction catheter, placed it down, and coincidentally it only went down 116 millimeters, the same length of the trach tube. And then again, we were right down in the tissue. And what we wound up doing is actually taking an end-tidal CO2 capnographer, putting it over his trach tube, there was absolutely nothing. Then we put it over his stoma site and over his mouth, and we were getting a waveform. So he was still spontaneously breathing, but just not through the trach tube, because like I said, I wasn't involved, created its own pathway. So with the cuffed tube, obviously we're going to, much like a combi tube cuff or an endotracheal tube cuff with a filled syringe, go ahead and put some air in there. And with those pediatric trachs, I think there's like a 10 cc syringe going around. With a pediatric trach, you might have to put in half a cc or 1 cc, if that, just enough to create an adequate seal. And then securing the trach tube. This is something that, again, every patient is different. On the picture on the left here, they're sticking one finger in for an adult. For the pediatric patient, we're basically sticking just a finger tip in. Talking with Don and his wife, with Taylor, Don said that he can barely stick a finger behind the tie there. It's so tight, and that's what she requires, because otherwise her trach is somewhat floppy to the point that she will come up and let the parents know that, hey, something's not right here. It needs to be a little bit tighter. As far as how to do it, basically, the different types of devices that are out there, there's what's called twill tape, which is just a darn expensive shoestring. Other things that are out there, especially with pediatrics, again, they're concerned about looks. You can have the Mr. T starter set up here, or you got the environmentally correct biodegradable hemp macrame ones. More commonly, though, we do have what are called the Dale trach ties, which I think I did pass one around. It's just a Velcro device that basically is just held in place with Velcro. Pediatric ones, they've got little clouds and bunnies and clowns and stuff on there. But again, a shoestring, whatever, that'll work also in a pinch. If you are able to, not able to reinsert that trach tube, again, now it's right back to the McVicar mode. So again, you can use a manual resuscitator with a mask from up above, from the nose and mouth. However, keep in mind, air is going to take the path of least resistance, so you will have to go ahead and occlude that stoma site on both an adult and a pediatric patient. Now, to throw a wrench in the works, going back to that patient that does have that complete trach or that complete laryngoscopy or laryngectomy where there is no connection between the upper airway and the lower airway, if we wound up doing this to that patient, where would all the air go? Right down to their stomach, yeah. So again, now it's time to jump into that McVicar mode. Other things you can do is take a suction catheter, place it through the trach tube itself, take that suction catheter, place it through the stoma, and then feed the trach tube over the top. But again, like I said, if those parents or healthcare professional at home can't get that trach tube in, you're going to be dealing with a stoma that my guess is pretty well chopped up and swollen and bloody. So, again, good luck. And if all else fails, just have the patient do it. And there you can see the stoma on her. It doesn't sit there and completely collapse or anything. She does fine, and she's got plenty of time to sit there and play around in the surge lube. So we have to remind her, hey, you're being filmed, put your trach in. And even at a young age, they start changing their own trach, and they know the do's and don'ts. She knows to put her chin down, not to cough it out. There she's just holding it in, puts her own trach ties on. So as far as coughing that out, the trach does become decannulated. Again, as far as the advanced life support interventions, attempt basic life support interventions first. Then consider, if needed, insert an endotracheal tube into the stoma site, and last resort, orally intubate the patient if appropriate while maintaining an occlusive dressing over the stoma. But again, like I said, that's going to be last resort. If we can make their chest go up and down and keep them pink with basic life support, that's what we're going to do. So if you do get to the point of winding up throwing an endotracheal tube in through the stoma, don't cut it. And we'll show you on a trach as far as how far to stick it in. Cuffed versus uncuffed tubes. I'm a stickler for cuffed tubes. Everybody. I put a cuffed tube in absolutely everybody. Reason being is the majority of the time when we intubate somebody, it's for somebody that's got sick lungs or will have sick lungs. So the cuffs are needed. Even in the pediatric population, they have cuffed endotracheal tubes all the way down to a 2.5. Much like an endotracheal tube or a combi tube, somebody must be assigned just to hold that tube. Another pet peeve of mine is when you see somebody bagging and pushing the stretcher at the same time. If you've got a combi tube or an endotracheal tube or a trach, whatever, have somebody maintaining that airway. And here, basically, you've got an endotracheal tube going through the stoma site, somebody ventilating, somebody reassessing breath sounds, and again, somebody holding that tube at all times. Conformation of the endotracheal tube, no resistance while inserting it, equal chest rise and fall, and again, you've got that 26 centimeter endotracheal tube or 30 centimeter. Remember, you don't have to stick it down all the way because you're going to wind up either having a right main stem intubation or a left main stem intubation. Equal breath sounds, hopefully that patient's skin color will improve and vital signs, end tidal CO2 to confirm either the colorimetric ones or capnography, also pulse oximetry. And as far as the dislodged trach logarithm, you know what? If someone has a dislodged trach and they need their trach back in, you're not going to have time to sit there and go through all of this. Again, basically do what you have to get their chest to go up and down. Going back to how far to stick that endotracheal tube in, if they do have a backup trach or the one that you're trying to get in, there's no reason in the world you can't use that as a guide as far as how far to stick that in. A pediatric trach versus an adult trach. And just go in that distance. So the O for obstruction, going back to that dope pneumonic, they might become obstructed due to improper positioning of the patients, secretions, bleeding, foreign objects, trach nose clogged, which is very common, or edema in the trachea, which is somewhat rare. As far as signs of a trachea tube obstruction, very much like that of a patient with some respiratory distress. Increased work of breathing, retractions, secretions, altered mental status, changes in vital signs, cyanosis, or if the patient is on the ventilator, they might be having some intermittent or constant high peak pressure alarms. As far as suctioning, again, we don't want to suction too deep, so you can use a backup trach as a guide, how far to suction down, or a obturator itself, although in the pediatric population, a lot of times they have a suction catheter taped to the wall that says don't suction any further than this, because you don't want to sit there ramming the suction cath up against the tracheal wall. As far as sizing, if they have a trach somewhere in that residence or in their go bag, they should have some backup suction catheters. Take them all with you, or generally 2 times the trach size is what size suction cath you should have. That will work out in a pinch. So, rule of thumb though, you can always go smaller with a suction catheter. For a single cannula trach that is obstructed, if we're unable to insert that suction catheter the depth that we should be able to, the obstruction is inside the trach itself. And again, we're going to try absolutely everything possible to suction. And my guess is, again, that parents and the home health care nurse are going to do it long before you get there. And my guess is the obstruction is in the trach itself. And my guess is, again, long before you get there, they're going to attempt to change the trach by removing it. If there's an obstruction in an inner cannula, again, this is the one that is nice because you can just go ahead, pop out that inner cannula, throw a new one in, and you've got a patent airway. However, if they don't have a backup one, you're going to have to clean out the one very quickly, put it back in, and keep in mind that inner cannula, that's going to be your lifeline to attach the manual resuscitator to. So if you haven't been able to ventilate the patient or insert a catheter past the measured depth, like I said, that trach tube itself is occluded, so you're going to have to remove the trach, and like I said, the obstruction is in the tube itself. If it's a single lumen trach with just one tube, again, always 2 people if you're going to be pulling somebody's trach, and this is probably the last thing in the world I would do in the pre-hospital setting. I hated doing it in the hospital, and like I said, in the back of the ambulance, I would be probably crapping myself in all honesty. And proper positioning of the patient, again, a towel roll behind the shoulders. Step 2, again, just go ahead and cut those, the twill tape or the shoelace. One person holds the patient, and again, bring that neck back, elevate the shoulders. Second person will go ahead and remove that trach. If it's a cuffed tube, however, if that tube itself is trached and that, or is occluded and that inner cannula by pulling that doesn't do anything, you can go ahead, deflate the cuff, Hopefully bag the patient from above with that cuff deflated. You should hopefully be able to get some form of chest rise. Deflate the balloon on that cuff trach tube and remove it. And here again, they've just got them cutting through the trach ties itself and pulling it out. And then again, reinserting it, water-soluble lubricant, 2 pre-pull, 1 to, pull the chin up, the stoma apart. So as far as the summary for changing, again, we're going to be gathering the equipment, laying the person flat in midline, and hopefully we'll be doing this here in a couple minutes. Hyperextending the neck, lubricating the new trach, deflating the old cuff, if it is a cuffed trach, putting in the new trach, removing the obturator, attempt to ventilate, securing the trachea, and again, or the trach tube itself, and again, confirming placement. So again, if all of that fails and we cannot get that trach tube back in, the absolute last possible ditch effort, which, a lot of us aren't even going to be doing this or attempting it, is, earlier we talked about the trach location is going to be below the cricoid ring, denoting the second or third or fourth trach ring. What landmark, emergency landmark, is still left relatively untouched for an emergency airway? Right above it, remember you got your cricothyroid cartilage, which is still going to be relatively left untouched. But again, doing a surgical airway on a pediatric patient or an adult patient in the pre-hospital setting, that's the absolute last thing in the world I want to do. But again, that's all good information that you can pass on to the hospital that, hey, we did absolutely everything possible to get this tube back in. It's just not working. And hopefully when you guys roll through the door, you will have a, somebody there ready to possibly do this if needed. So as far as the type 2 of obstruction, if you have been able to insert the suction catheter and to the measured depth and suction, the assessment, there's just absolutely no change. The obstruction is below the trach tube itself. And if it's below, again, we're going to go right back to our basics, attempt to suction. Other things you can do, if it is a big old plug of secretions, we can instill some saline down there, either have the patient spontaneously breathe it around, or if they can clear it, or we might have to go ahead and assist ventilations with the manual resuscitator to hopefully loosen up the secretions, and then go ahead and suction. So a couple cc's of normal saline, bag the patient, get the secretions moving around, and then suction. And that's what we're doing here. And as far as how deep, again, we don't want to be suctioning on the way in. We want to measure prior to going in. We don't want to go down too deep. Insert the suction without applying the suction. And once we get in there, go ahead, apply suction. And then again, especially with the pediatric patients, they become hypoxic pretty quick. So again, limit it to 5 to 10 seconds at the most. Twisting on the way out. But again, if you've got secretions coming out of the trach, there's no reason you just can't go ahead and suction them right on the way in. More suctioning, and then afterwards, again, supposedly, where you're depleting the patient of oxygen, go ahead and reoxygenate them. And again, just another logarithm that is in not your handouts, but it is online. And the P for the pneumonic dope, pneumothorax, again, this can happen, especially with bagging kids if you're not used to it, or even adults. Again, we're talking about, the adult airways or the adult lungs have approximately 300 million alveoli, all the thickness of a soap bubble, which takes very little pressure to pop. High peak inspiratory pressures can definitely pop those alveoli, or high levels of PEEP. Vigorous bag valve mask or bag valve attempts to the trach, or again, if that patient has just weak airways due to COPD or some other underlying disease, again, also possible, as well as your trauma patient. And again, the signs and symptoms of a pneumo, we're not going to sit there and, most of you know this, you should all know it: shortness of breath, decreased breath sounds, tachypnea, cyanosis, low pulse ox, tracheal deviation, which is a very late sign, and then subcutaneous emphysema. But again, besides all that stuff, just look at your patient. Just unilateral respirations, either from looking at that patient's from their feet or looking at their head end. Does something look wrong in their chest there? Yeah, something's not going on, or something's not happening. So as far as the assessment and the management, you might have a dropping blood pressure, poor perfusion, altered mental status, absent lung sounds. And as far as management goes, basic life support, medical control, and think about a ALS intercept. And ALS, depending on where you work, they might stick a needle through the chest and do a needle decompression. There's a little critter with a tension pneumo, where how well do you think that left lung is oxygenating and ventilating? What about that right lung? And we always think lungs, 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 but what do you think is happening to that heart also? Again, that's probably like an elephant standing on the patient's heart. And they always say that a chest x-ray of a tension pneumothorax is a sin. Why? And basically, you should pick up on the fact that something is going on long before you get the x-ray. And as far as sticking a needle through, they always sit there and they say, oh, you're going to hear this big rush of air and blah, blah, blah. With all the needles I stuck through a patient, I've never heard of rush of air until last year. We had some trauma patient that got extremely hard to bag when we were flying. We were landing, and tube position didn't change or anything, and looking at his chest, just something wasn't wrong. We wound up needling this guy, and with our helmets on, with the helicopter running, it sounded like a whale spouting. I could not believe it. There was just that much pressure. And then right before we were unloading the patient, looked up at the ceiling of the aircraft. I don't know if you can see it on the slide. You can see all the blood splatters. So I'm sitting there yelling to the patient, don't clean it. I got to get a picture of it. So there was that much pressure inside the patient's thoracic thorax. And the last, the E from the mnemonic equipment is, as far as equipment problems, you walk into some of these residences with patients that do have children with special health care needs, they have got more equipment than most third world hospital ICUs. And just looking at that stuff, you know what? It's a machine. Things go wrong. And I'm talking with Don and his wife, and they said basically for everything that they have equipment-wise, they have got a double, a backup one. So 2 ventilators, 2 humidifiers, 2 everything, in case if something does go wrong. But equipment problems, again, you might have oxygen issues, tubing issues, disconnection, obstruction, the trach kit's not ready to go. As far as the home vents go, they can be nightmares on their own, power failure, unplugged from the outlet, or you might just have problems with the battery or the vents, battery failure or a dead battery. Or the trach tube itself. Sometimes trach tubes are reused, and again, you can't really see it on here, but it's basically a cracked trach tube that is cracked off and just sitting above the patient's carina. For all equipment problems, again, even though they might be on that $25,000 vent, the first thing we are going to do is take them off that $25,000 vent and go right back to our basics with regular bag valve mask ventilation to the trachea. And we're going to attempt to ventilate the patient using our basic means with supplemental oxygen, see if it's making a difference, and if it is making a difference, chances are it's the equipment that's a problem. And then, besides just taking the patient, also take the equipment to the hospital so we can take a look at it and hopefully determine what's going on and get it corrected. Alrighty, who's the old guy? Yeah, which old guy, right? No, one old guy is my dad. The other one, Baden-Powell. Lord Baden-Powell, founder of Boy Scoutings, came up with the term, be prepared. This is what it truly comes down to. Like I said, there are more and more of these, not only kids, but adults in our communities, and a lot of times we know nothing about them. And these days with HIPAA and stuff, unfortunately, we just can't sit there and find out about them. You know, years ago, we wound up having a little kiddo come into our community, and they called the fire department and said, yeah, they're going to have compressed gas on the premises. You need to know about that. And thank goodness the fire chief said to the EMS chief, well, wait a second, you know, there's going to be a kid in our community that has a hole in his neck. Don't you think you should know about that too? And so with just communication, we were able to get some information. These days, though, however, most of the hospitals are very good about notifying the local rescue personnel if somebody with special health care needs are coming into their community. And so through the American Academy of Pediatrics, there are some flow sheets out there that you can keep on file that if you do get called out to a certain residence, they do have a child that has a trach, basically it lists all their medications, their past medical history, where they should go, etc. And remember your resources. There is no reason in the world that when you get toned out to that kiddo with a trach, there is no reason in the world you can't call that hospital right off the bat and say, you know what, hey, we're going to go deal with a kid that's got an obstructed trach. Just stay next to the radio in case if we need the assistance. When and where to transport, again, you know, some of the stuff, think about it, whether or not to transport if the child is febrile with a fever. They might have some type of infection brewing. If the oxygen saturations are lower than usual. EMS has had to change the trach again to bring them in and just confirm that it is in the correct place. Equipment failure, and again, bring the equipment. And then the family might be stressed or distressed. And like I said, if they can't figure out what's going on, you know, chances are something's going on. Prior to transport, again, there are some things that we definitely want to take. Everybody that does have a trach does have a backup trach somewhere. Bring it with you. I always go back to the story about a patient that we had that had what's called a custom-made trach. There are only 2 of them in the world. One of them in his neck, the other one taped to the bedpost at home. And he would come in, and I'd always ask him, hey, where's your backup trach? He'd plug his trach and say, well, it's at home. And I'm like, well, what good does it do it at home? And every time he would come in, if we ever did have a trach emergency, more times than not, we wound up pulling out that trach and sticking a 6.0 endotracheal tube. And I remember he had a 118 millimeter 6.0 Shiley trach that was custom made. I'll remember that till the day I die. But yeah, we'd put an endotracheal tube in, which, again, if you've got a backup trach, there's no reason for that. So suction catheters, again, take some extra suction catheters, especially if you got the tiny ones, and don't be, take the stuff you need. Don't be taking the plasma TV or whatever. So again, assess the patient. ABCs, ABCs, ABCs. The suction, oxygen, again, reassess the ABCs. Change the trach tube if needed, but like I said, that's one of the last-ditch resorts. Make sure you do have that emergency bag coming with you. Take all the patient's life-saving equipment, again, the vent, bring all that stuff with you, even though you're not going to be using it en route. Include a copy of any type of specialty forms if they do wind up having them. And one of the family members, if not two, should come with you. And chances are, what are the chances of you telling mom and dad, okay, we'll just meet you at the hospital? Nah, they're saying, you know what, one way or another, we are coming with you. And I always say, what's the difference between a terrorist and the parent of a special needs child? You know, you can negotiate with a terrorist. So, alrighty. So how are we doing on time? Do we have time to bring our all-star up here? Kaylee? So what we're going to do is, this might be a little AV nightmare here, but hopefully we're going to be able to, we're going to clear the table up here, and what we're going to do is show you Haley's trach, as well as, if she is up for it, do a trach change. This is her father, Don, walking her up here, and like I said, he's a paramedic student down in Illinois. And he asked if he was dressed appropriately, and I said, you know what, this is your first vacation in 10 years. Do you think these people are going to care how you're dressed? So, is it on? Okay. Actually, we're in luck because she normally stands up when she does it, so why don't we bring her out in front here? Yeah, I'll just put them right here. Yes. You'll be okay. And then afterwards, if time permits, Don and his wife will answer questions. And like I said, this is the absolute best resource right here. So if you have questions or if you want to come up later, by all means do so. And hopefully we're going to be able to focus the camera on Taylor when she's standing here, and you'll hopefully be able to see a trach change right in front of you. So.
And Stu, we have 15 to 20 minutes, and we would like to use that full 15 to 20 minutes. So
is that a hint?
Yeah, that's a hint. Lunch will not be ready for you guys to go out and get until noon. So I got in trouble for releasing you early yesterday. So I'm going to lower one of the lights down so that you get a little more light on her so you can see her. Is that all right?
That's fine with me. And also, Don does have their emergency bag here, where also later what we can do is just lay out the contents of it just so you can see what's in there. You know what? I'm going to put the microphone on Don. Hopefully you won't have any Tourette's outbursts here or anything, but
If I fall off, you gotta hold it.
that's fine. That's fine. And you can, if you just want to say what you're doing. Okay, I'll stay there.
Yeah. The first thing we usually do is make sure that the trach that's going in is ready and correct, and I have it backwards. Can you hold this?
Yep. You're rotating, I'm holding it. There we go.
Especially if you have the time to double check everything, have your partner double check it, because if it's backwards or incorrect and you take that one out, it's too late. first time I've done this in front of this many people, so. What was that? All right, let me have this side.
You got it?
Yep. Okay, I got it.
Okay.
Are you ready? Chin up.
There we go.
Cough it
Now you
up.
can see that obturator comes out pretty quick.
With that inside there, she can't breathe at all. It's obstructing the entire airway. And like Stu said, some kids, there's a million different ways to tie a trach on. With her, because she's active, she likes to dance, she likes to play, her trach ties have to go extremely tight. The doctor just switched her to a Bavona trach, which has steel rings inside it to make the trach tube a little bit stiffer so that it doesn't bend as much because she was active. Okay. Spit it out. Spit it out. There you go. All right. Let me get her some.
Okay. Okay. Is that better? You okay? Better? Any more? Got it? Plan. Be like I'm on American Idol with that thing. So, sometimes underneath the trach itself, sometimes they will have trach pads, which are basically just 2x2s or 4x4s with a slit in them. Sometimes either kids or adults will have those in. And again, every kiddo is different. So, on Taylor here we don't have them in, but like I said, sometimes it will. But there you can see the procedure actually goes pretty quick, and for the most part, the kids tolerate it fine. And but once you get that trach in, like Don said, with that obturator still in place, again, that's her airway, and that airway is occluded, so that obturator has to come out. And usually, like I said, just by inserting anything into a person's airway, usually you get some form of coughing and stuff, and they want that out of there pretty quick. And again, you have to realize that, yeah, when that trach goes in, you know they're going to wind up coughing, so make darn well sure that somebody is holding that trach in place, because otherwise, you know, all that effort, they wind up coughing it out. So make sure someone is dedicated just to secure that trach tube itself. So other things to have ready, make sure you've got suction available. Make sure, again, if they can't get that trach in, also think about having a manual resuscitator as well as a mask readily available in case if you have to use it. So, are there any questions at all? Yes, ma'am.
Once a week.
The question was, how often does she get her trach changed? And again, everyone is different. Tyler here gets it changed once a week, or sometimes also it's just as needed if something for whatever reason is going on. So, any other questions at all?
Raise hands for questions. We've got 2 mics to wander.
We've got time to burn here, so.
I'm curious as to why she had to have a trach placed in the first place.
She was born with Vater's syndrome. Every kid that has that syndrome has different abnormalities. Hers were, her esophagus was connected to her trachea. So at a little less than a week old, they had to operate. They removed every piece of esophageal tissue from her trachea except enough to close off the trachea so that it was an intact airway. So now she has tracheomalacia. Without the trach tube, if she breathes in, her trachea collapses because it's esophageal tissue in the back.
Will she be able to live without a trach at some point?
We have no idea.
So the question is, will she continue to need a trach for life? Will she be able to be without it?
We don't know yet. We're working on that. We're trying to find ways to correct the problem, to permanently fix it. But so far to date, one of the procedures that she needs done as an esophagus is, I think it's called a colon, something to do with the colon. They detach part of the colon and bring it up and attach it to her oropharynx or to the esophagus, and hopefully it learns to swallow. But she doesn't have enough colon. She has no esophagus left, so they can't do that. So that goes along with fixing the airway to correct both problems, but they can't do one, the esophagus, so we don't know about the trachea. Hopefully, if nothing else, as she grows, the tracheal cartilage will grow around to where it should have been in the first place, to enough where we can decannulate her and leave it. Stay here. Question over here?
You had a picture up there with a boy in the water with a trach. It just doesn't seem.
Yeah, that's, you know,
I said the same thing.
that's one thing that there are a couple pictures out there. There is a camp foundation called the Boggy Creek Camp, which if you look on the back of the Paul Newman's salad dressing or whatever, it says all proceeds go to Boggy Creek Camp, whatever. There are several of these camps throughout the nation, one of them being down in Orlando, Florida, that I've gone down to a couple times to volunteer at their asthma camp. And they have what is called quad camp down there, where the first time I saw pictures of these kids on inflatable rafts that are ventilator dependent in the middle of a swimming pool being bagged with a manual resuscitator, it was like, what are you people thinking? But on the other hand, I'm thinking, you know what? This kid is probably having the time of his life. They take these vent-dependent children in the swimming pool, on horseback, you name it. They take them up this climbing tower, they hoist them up there, and again, you know, any kid with, you know, the kids with the special needs, they're kids. They want to be kids. They want to be like every other kid. So yeah, you know what, taking them in the swimming pool, you know what, have a plan. That's what it comes down to. And again, just let them know, hey, you know what, probably not a good idea to go underwater and hold your breath or something, but, you know, stay in the shallow end. And but Boggy Creek, like they do have a website, and they've got some pretty impressive pictures on there on what they do down there. So, and most of the camps like that are staffed with a on-site physician as well as nurses, respiratory therapists, etc. So, as well as they are looking for healthcare volunteers. So keep that in mind. Any other questions? What's that? She is being our star.
She loves her dance class. She likes to dance.
Any other questions?
If you don't have more questions, you're going to have to listen to me. Your questions are more interesting.
You want to dance? You got any music? If Stu will
And I
sing,
don't think
she'll
you want
dance.
me to sing.
I was going to have Stu sing.
We have a question.
We got one coming up.
I'm actually very curious because you said she likes to dance and to move around a lot. Does she, I mean, how does she do that having, you know, respiratory difficulties? Does she have, you know, the respiratory capacity to do all the activities that other kids her age do?
It's coming slowly. You know, at first, when she first wanted to go out and play with her big brother, she only lasted a little while, maybe a half an hour, and he plays all day. But as she's growing and developing, her tidal volume is about the same. Her energy is endless. She goes to bed early every night. She wakes up early every morning. She usually wakes her brother up to go play. When she gets tired or when she's having trouble breathing or she has COPD and, you know, a lot of secretions in her airway, so if something's wrong, she'll stop and come and get us and tell us, I can't keep going, or I need to go to bed, or I need suction, or whatever she needs, she'll tell us. So she can't, and once we do that, she'll go back out and start playing again. So as long as we maintain that, you know, she's breathing okay and her oxygen saturations are fine, then she'll stay playing all day.
And in as far as activity level in the children's hospital, we had a patient population, the kids with cystic fibrosis, where they would require anywhere from 2 to 4 therapies a day to help loosen up secretions, and it was the I'm not quite sure if it's a physical therapy or which branch developed it, but it's almost like a exercise therapy class where they would go to exercise therapy and they'd sit there and have them jump on a trampoline or whatever, and they were finding out that, you know, just getting these kids active, get them moving, get them taking deeper breaths was more beneficial to loosen up these secretions and cough them out versus doing therapy. So yeah, the exercise is good. Question in the back? Got a couple here.
I've on 2 different occasions had to assist ventilations through the tracheostomy in code situations. And in one, we were able to do the BVM through the trach without any problems. The other ones, we had to switch to the BVM orally and plug the trach. Now, which is normal? Should you be able to bag directly through the trach or not?
You should be, but again, like I said, it comes down to McVicar medicine. What is going on? If you can't bag through the trach, the chances are there's an occlusion in that trach. And that's, you know, we try and get rid of the occlusion first. However, if that fails and you can't change out the trach for whatever reason and you have to do bag valve mask ventilation from above, again, you got to be thinking, well, if it's a cuffed trach and that cuff is up and that trach is occluded and I'm trying to force air down from above, you know, it's going to go to, so like I said, you've got a lot of decisions to do in a very short period of time.
What we were finding was there was a lot of air leakage around the stoma when we were using the trach. Is that, I mean, obviously that shouldn't be a normal.
So my guess is it was probably an uncuffed trach.
Correct.
Correct. And again, the air is going to take the path of least resistance.
Okay.
And like I said, sometimes patients do have 4x4s or 2x2s built up underneath there that truly doesn't occlude or stop the leak. It might help the leak, but you could put, you know.
My thoughts exactly.
Out of the mouth of babes.
Highlight of the conference. We'll have you back.
Yeah. So with one thing you can do with even moist gauze or 4x4s or whatever, just kind of put them up underneath the stoma site itself to help stop that leak. So and like I said, there are no true answers. It is all trial and error.
Stu will be available for any additional questions for 5 or 10 minutes afterwards. How about a big round of applause for our star? I'm awfully glad I'm not following this act.